Okay, everybody, welcome to our video lecture on disordered eating. So the first thing I want to talk about is suicide rates. Now, remember, we have a whole module that's on suicidality, and that suicidality is its own concept and isn't a diagnosis in and of itself yet, but is something that we want to pay a lot of attention to. Many people assume that mood disorders have the highest rate of suicide. It's much more complex than that. Mood disorders have a very high rate of suicide, but in some studies, what we find is that actually these disorders have the highest rate of suicidality, particularly body dysmorphic disorder and anorexia nervosa. As you can see, some of these numbers here estimate that it is greater than the general public by up to 45 or 58 times. One of the things that I think is really important to pay attention to is that when we look at disordered eating, including body dysmorphic disorder, there is a high rate of comorbidity with other mood disorders. So many people who meet the qualifications to have a eating disorder also will have a co-occurring mood disorder. This may explain why this category of disorders has such an incredibly high suicide rate. And two, that eating disorders, regardless of their suicide rate, have the highest mortality rate. Of all of the disorders in the book, the one that you are most likely to die from is disordered eating. And a lot of that has to do with what eating disorders do to the body on top of the malnutrition. You add even a subclinical mood disorder in on that, and those numbers get really scary. So if I, Dr. Wolf, ask you on like an exam, what category of disorders or what disorders have the highest rate of suicide? You would tell me disordered eating, specifically body dysmorphic disorder and anorexia nervosa. If I ask you which disorders have the highest mortality rate, you would say disordered eating. But if other professors ask you, you probably want to go with mood disorders and schizophrenia. Those are two big players. And if you don't look at the mortality rate and only at the suicide rate, and you don't pay attention to when mood disorders and eating disorders intersect, then schizophrenia and mood disorders have the higher rate. Basically, this whole category of research gets really hard to make cross-article comparisons because of sampling issues. But if I was to generate like a list of the disorders that have the highest suicide rate, then it would be mood disorders, schizophrenia, and disordered eating. And that everyone can agree that the one with the highest mortality rate is disordered eating. Now let's talk a little bit about body dysmorphic disorder. Body dysmorphic disorder is technically covered in another part of the textbook, but it fits better with this group of disorders because it's about body image. Body dysmorphic disorder is when someone perceives flaws in their physical appearance that are not observable by others, or if other people can see it or observe it, it seems very slight. The interesting thing about this is that the most common area of concern for adolescents is the skin. And if we look at people who are seeking cosmetic surgery, usually a high percentage of those seekers will show signs of body dysmorphic disorder. In fact, a Belgian study found 43% of patients seeking a nose job showed signs of body dysmorphic disorder. Now you have to ask yourself, if the reason why you want cosmetic surgery is because you are perceiving your flaws differently than everybody out here who has eyeballs, and you get the surgery, does this fix the problem? No, it doesn't. And in fact, that rate of the number of patients with body dysmorphic disorder, clinical or subclinical levels, goes up on second and third and fourth surgeries. So that by the time you start looking at people who are seeking a third nose job, like up to 90% of those patients actually meet the criteria for body dysmorphic disorder. That's a little problematic, right? Now in this lecture, you're going to hear me talk about disordered eating instead of eating disorders. That's because the term disordered eating is actually an umbrella term that includes both people who meet the criteria for a eating disorder and people who have subclinical levels of disordered eating patterns. And when we look at disordered eating rather than specifically eating disorders, people who meet the symptoms, if we look at this as everyone, right, who has a collection of these problematic eating habits, they become incredibly common. The DSM has a whole chapter called Feeding and Eating Disorders. Some of the ones that aren't the ones that you may have heard of, like anorexia and bulimia, but are still very interesting are, for example, pica. Pica is one of my favorite disorders. It's not my favorite, but it's one of them. And if you ever get a chance to watch like My Strange Addiction, that TV show with me, you'll hear that through most of it, I just scream at the television. That's pica! Pica is when you eat non-nutritive substances like clay or dirt, and that you're not at a developmental level where this is common. There's plenty of little kids who will stick all kinds of things in their mouth and chew on them. So we're really talking about after that age, a person starts eating things that aren't food. Why do people eat substances that aren't food? Specifically things like clay or glass or whatnot. Well, there's kind of two camps of thought. So when we look at pica, there's kind of two categories. There are the people who eat clay or dirt or sand and those sorts of things. Now, clay, dirt, and sand, those aren't food, but they all have minerals. Now, the body, right, you're made up of a certain percentage of these minerals. And when you have them, you're good, right? But let's say, for whatever reason, right, someone is deficient in minerals, right? They're not good. So there's an idea that your brain, right, knows that they need minerals. And that subconsciously, it causes you in your stomach, right, to want things like clay and dirt because you know on some level that that might have the minerals you're needing. So these cravings, right, lead you to eat the dirt, right, which might increase your mineral content, making you happy so that you don't crave them until your mineral content goes down. The other camp are people who eat things like nail polish, right? Or the stuffing inside a couch. Or really anything else that you might have heard of people eating that aren't food. Now, none of these have a mineral content. In fact, they're pretty dangerous for you because they can do all sorts of bad things to your system. Like nail polish has all sorts of toxins in them, and things like stuffing or even hair can create what's called a bezoar, where there's a blockage in your bowels. So in here, rather than the brain craving a mineral, we talk about that you, for whatever reason, right, eat the odd substance. And after eating that odd substance, right, you feel better for whatever reason, usually a psychological reason. And that this tells your brain, right, hey, that thing worked. And then when you start feeling sad again, your brain says, hey, what about eating that thing you shouldn't eat? And then you're like, okay, I'll eat it. And then I feel better. It's a behavioral addiction of kinds. And that's one of the reasons why pica shows up on that show. It's actually more like an impulse control issue. But the problem with pica is that the diagnosis isn't specific as to whether or not there might be a mineral content to this thing that's not food, or whether or not it's just not food. Either way, if someone craves and thus eats things that are not food when they are not developmentally small enough to do that, then that's going to be pica. Some of the other disorders that are listed here are rumination disorder, which is about chewing, re-swallowing, and spitting out food, again, at a time that's not developmentally appropriate. Sometimes this leads to the development of another eating disorder. And some others, like restrictive food intake or night eating syndrome. I'll let you read more about both of those. I want to spend an extra minute on something that's not in the DSM. Prader-willi syndrome. Prader-willi syndrome is not in the DSM because it's not a psychological disorder. It's in the ICD because it is a medical disorder. Specifically, it's a birth defect around a certain chromosome. And this chromosome issue causes lots of problems, but one of the problems it causes is what we call hyperphagia. Basically, the brain thinks you're starving when you're not. Well, the brain tells you are, so you experience hunger, and thus you try to overeat. This is a major problem for not only people with Prader-willi or Prader-willi syndrome, but the caregivers. Imagine having a 4 or 5-year-old who you just fed a nutritional dinner, but is screaming and crying because they feel like they're hungry. They feel like they're starving, and they're begging you for food. So while us, as mental health professionals, don't always see people with Prader-willi syndrome, we do sometimes see the caretakers. If you're interested in this, I'll put a couple of optional videos in the module that are about this syndrome. Now let's get back to your traditional eating disorders. The first one is anorexia nervosa. The key here is that anorexia nervosa is when someone restricts how much they consume, so much so that they have a significantly low body weight. In addition, they have an intense fear of gaining weight. Now, one of the difficult parts about understanding disordered eating is that there's actually 2 subtypes of anorexia nervosa. One of them is the one that you're probably used to seeing on TV, which is the restricting type, which is where it's just about a restriction of how much caloric intake that person has. But there is a binge purging subtype of anorexia nervosa, where someone restricts how much they eat, but occasionally has a binge episode and then does a lot of purging behaviors. Now that sounds like something you probably have heard of, which is bulimia. So let's look briefly at the criteria for bulimia. In bulimia, notice that the criteria is about having recurring episodes of binge eating and that you have some sort of behavior that you do to prevent the weight gain from that, like a purging behavior. Notice that it doesn't say anything about having a low body weight, but the criteria for anorexia does. So basically, anorexia is where you restrict your food intake to the point where you have an incredibly low body weight and an intense fear of gaining weight. And that sometimes all you do is restrict, and sometimes you restrict and have a binge purge cycle. And that bulimia is when someone doesn't have that intense fear, doesn't have that dangerously low body weight, and only has that binge purge cycle, not the restriction cycle. So it can be a little confusing for people who are just learning about these, but that should help you clarify the difference between anorexia, binge purge type, and bulimia. Now there are some other slides in here that tell you a little bit more about prevalency rates and mortality rates and that sort of thing. But there are some other eating disorders that are in the chapter, including binge eating disorder, which is new for this edition of the DSM. This is where someone has those recurring episodes of binge eating, but that they don't have the inappropriate compensatory behavior. They don't purge or restrict after they're binging. It's just the binging. I think it's important for us to talk a little bit about race and ethnicity and some other cultural identity pieces when it comes to disordered eating. First of all, I think there's some terms that you need to be familiar with. There is acculturation, and acculturation is when someone starts to change after a meeting between 2 different cultures. Particularly, there can be acculturation, which is where someone starts to behave or speak or perform cultural behaviors that are like the dominant culture, and there's enculturation, where one learns those requirements, doesn't necessarily always perform them, or more importantly, only performs them when they have to, as opposed to it being part of who they are. If you look at some of the studies that are about this, what we find is the group that has the highest rate of disordered eating are white girls. Now, it's important to note that men and boys also have disordered eating. So if we just want to focus on the race and ethnicity part here, it's really about white Caucasian children and adults tend to have the highest rate of disordered eating. But it's not quite as simple as that. Notice the study at the bottom that's about Cuban American women, and that the close identification with Cuban culture was associated with lower EAT scores, which is a measure of disordered eating. Also find the next one, that second generation Mexican American women that were more acculturated had higher disordered eating. Basically what this means is that the more that you align with kind of the dominant culture of the United States, as opposed to your own ethnic culture that is different than that, the more likely you are to have disordered eating. In addition to race and ethnicity, we can also look at sexual orientation. And what we find is the closer that you align to your identity as a lesbian, the more likely you are not going to have an eating disorder. However, if you are a man and you are gay or bisexual, you are much more likely to have an eating disorder than if you are a lesbian. Further, there is some evidence to suggest that the closer that you identify with the LGBT culture, the less likely you are to have an eating disorder. Basically, what we find is that if you have an ethnic identity that is not Caucasian American, and you align strongly with that ethnic identity, it's a protective factor. And that the more you identify with kind of the dominant culture of the United States, the more likely you are to have an eating disorder. And that the gender ratio gets swapped if we look at people who have a diverse sexual orientation, that people who are lesbians seem to be protected, and people who have a real strong tie to the gay community seem to be protected, but that men in the gay community, bisexual and gay men, both have dramatically higher rates of eating disorders than the rest of the community. Finally, I want to highlight that multi-path model that's in your textbook, and pay attention to those biological factors, those psychological factors, and those social, cultural, and social factors, particularly the social cultural factors. In addition, there appears to be a fairly clear route to developing an eating disorder. First, a person performs some social comparisons. And if they do that in a culture where there's a high pressure to be thin, and they have internalized that being thin is somehow ideal, then this comparison leads to body dissatisfaction. That body dissatisfaction then causes that person to do what I would say, instead of dieting there, disordered eating. And that body dissatisfaction causes me to have a bad affect, to feel bad about myself. That negative affect reinforces my disordered eating, and that disordered eating reinforces my negative affect, and those spiral towards developing an eating disorder. You should probably pay attention to this model here because you might see it. The other real problem when we look at disordered eating is this stuff starts really young. Remember that grades 5, 5th grade, you're 10 years old. So we have 10, 11, 12, 13-year-olds who are sometimes or very often on diets. And anything that starts when you're young and there's not a good early intervention usually has a poor prognosis, which is one of the other reasons why we think disordered eating is so rampant in our culture. We're going to stop there, and I'm going to make an additional video on body image before the exam for this unit. But this video is already getting kind of long, and I don't want to make it even longer by talking about body image. So make sure you watch the second video when it's posted, and I'll see you on the internet.